Brijesh, he needs to make his ICU a kind of place. Brijesh, what do you mean? Do you think that it's not a kind of place now? Brijesh?
Yes, Murali sir.
That's not entirely true. I won't agree with you because there is a system failure due to time constraint, resource poor settings like us, and lack of processes in our country, and not due to ignorance. We all know about this, and but we don't have any resource, we don't have no processes and time constraints and system failure. And we need a culture change to get the ICU into a kind of place. Am I correct, Brijesh?
Yes, very true.
Yeah. Thanks. You can interrupt in between. It is not a monologue, and we can take it as a knowledge sharing thing. And you people can interrupt me at any time, and we can clarify, and you can also contribute. Kindness is humane, no doubt about that. So everyone in healthcare setting will be having it. No doubt about that. Everybody is having a kindness that is humane. So I searched vigorously, and the search engine took me to a concept called humanizing intensive care, a human-centered care of ICU model. If you search a human in an ICU, the net will take to this area, humanizing intensive care. The kindness is modified into this word is given in majority of the online materials. And these are the two names surfaced by surfing. First one is Samuel M. Brown. He's a respiratory medicine specialist from Intermountain Hospital, Ottawa, USA. And the other person is Gabriel Heras. I met him 3 years back and discussed about this humanizing ICU care. He's from Spain. And he's also head of the Department of Critical Care Unit in Spain. And both of them wrote many books on humanizing intensive care, and majority of papers regarding this humanizing intensive care are from them. And Latin American countries, US and UK, are very fond of this concept. So there are haters. They might be objectionable, saying that it won't suit our culture. These are all for English-speaking community. They will say like that. But I don't agree with that, because our father of nation, Mahatma, he said rightly that the greatness of humanity is not in being human, but being humane. As all of us know, East or West, India is the best. We can practice it. We do have patience, but resource poor country, even then we can practice this. Somebody may say that this is a new concept. Why do you go behind? No, not at all. This is by a Francis Will Peabody. This journal, this write-up was published 100 years back in JAMA. So it's not a novice concept as we think. And there are many scholarly articles. If you search, and here hundreds and thousands of scholarly articles you will get. Everyone is having a best of evidence, considering a clinical expertise and the patient values, and it's worthwhile to think about this concept and discuss about this concept. As Dr. Murali rightly said, when you think about ICU, you think about RRT, intubation, flow volume loops, and all. But in the layman, when you think about, when you go into an hospital and in front of an ICU, you can see a red ICU signboard like this, and a closed door like this, and a long corridor with a light fitted on top of it, which is very, very bright, and sad faces without any chair. They will be roaming around, crying, and kneeling forward and praying. This is the picture we get into a human being when his loved one gets admitted into an ICU. Red signboard, closed doors, a long corridor, no chairs, scorching lights, and sad faces. This is what we get. At times, the door gets open and the nurse sneaks and yells for somebody's relative. This is what usually happens in front of an ICU. Let us go in and see what happens in an ICU. What is happening inside an ICU? Let's see this short video. You can see bright light on top of it with the white walls and lights, curtains, sounding alarms, unfamiliar faces coming to you and asking to and speaking to you in a different language at times. Another person comes and putting light onto your face. Then comes another person. He's going to give you a pain injection. And she came back with a suction. She's going to put it into your mouth and suck it out. It will also inflict pain. So this is what usually happens inside an ICU. Sounding alarm, dull white walls, unfamiliar faces, overhead lights, all inflicting pain to us. We torture them by isolating them from the family, losing their personal preferences because they are admitted into the ICU and there are no personal preferences. Their personal life ends there. They will be patients. We consider them as patients and calling them by disease, sepsis, urosepsis, ARDS, and ending their personal journey there and call them as disease and put them in a cold cells with no natural lights, and overhead high intensity lights are also there. Noisy surroundings and overhead high intensity lights will also be there. And this occurs because in our professional journey, though we have superlative technical skills, we lose our communication skills, emotional connect and empathy and spiritual skills very frequently. This is what happens. This leads to what? This makes us to be rude towards the guest. Better call them as guest rather than patient, and their family and ourselves. So it is time we should be much more kinder, as Bridget said, to counter the dehumanizing attitude we just saw before in the video, so that we will be kinder to the patients, professionals, and their family. This is what Bridget made. So we searched and we found out that there are 7 ways you can counter the dehumanizing trends which is practiced nowadays. First one is humanized architecture for improved guest experience. Hereafter, I will be saying the patient, addressing the patient as guest. And liberal visitation for family well-being so that they can enter at any time. Mindful communication to prevent burnout among ourselves. And soft skill training for the staff so that they become better communicable persons. No may charge for the personalized care, for providing personalized care for the patients. No guest. ICU diary for better communication. I will come to that. Post-ICU clinic in the name of Phoenix to detect and tackle PTSD and post-ICU syndrome. All these 7 things satisfies the EBM triad because they work on best external evidence with the individual clinical expertise, considering patient values and expectations. So all these 7 is also having EBM triad positivity. So we can very well practice it. I will come to it one by one. This is called humanized architecture. How can we make our ICUs much more palatable to our patients, our guests? This is an old concept. This is what usually we see 10 years before. Closely placed beds, dull curtains, moved apart, scorching lights on the top, and sounding alarms because they are pumped in with the technological advances, and white colored dull walls. And this is what the usual look of an ICU 10 years ago. What we did was we removed the sun controlled films so that welcoming natural lights, and painted our walls with the soothing shades like pastel colors, and removed overhead lights and fitted with the foot and dynamic lighting system. I'll come to that. And removed alarm fatigue so that ICUs will be quieter compared to the previous days. Making the ICU look like this, guest friendly, providing cubicle concept, windows and loads of natural light, dynamic lighting facilities so that you can see different colors over there. It changes color as the day advances. It can be controlled by the patient as well as by the carers. Wired with the screen and it's very quiet and less than 50 decibels inside the ICU. And all these senior nurses will be carrying sound level meter. They adjust the alarms in such a way that it sounds only when there is an emergency. So removing the alarm, and clocks and calendar for the orientation, and spectacles and holy books of their choice is also provided into the ICU. And we made up our counseling room look like a hotel lounge. It is aromatized with essential oils, and there is no traffic in between, and it is quiet, and its decibels are kept below 40 dB as per the WHO recommendation. And you can see holy books are placed over there, and it is wired with the music and for the better well-being of the patient. And this is what dynamic lighting is. It maintains sleep-wake cycle. Let's see this video, then I will come to that. A short video on dynamic lighting facility. No doubt that it improves the well-being of ours as well as the guest. It maintains sleep-wake cycle, ensures 6 hours of assured sleep to them, and prevent ICU delirium because the circadian rhythm is maintained, so as decreases the length of stay, reducing the cost. That's what we need. A kind of means decreasing the cost as well. And let's come to this music. And we also wired our ICUs with a music system, which plays string music as well as wind. No vocal songs are being played. Let's see which type of music is played inside the ICU. This type of strings are played in the ICU, not as a nuisance. It is at a low volume. That sounds are called white sounds, and it's not red sounds. If you listen to this, it decreases the stress levels of ours as well as the patient, and decreases the ICU delirium, and decreases burnout in healthcare workers, and improves well-being. And this is called music therapy. Regarding this music inside ICU and inside operation theater, I have a fond memory with Dr. Brijesh. He is very younger to me. I joined for MD anesthesia in 2002 at Calicut Medical College. Brijesh was 1 year senior to me, I think, or 2 years. Brijesh used to carry a transistor radio, and along with it's a tape recorder, I think, and it is with me still. It is working, and it was given to him by Dr. Bob, and he handed over to me, and I still carry that because on the days, almost all duty days, we do take this tape recorder into our theater, in the emergency theater. We do play music. Brijesh,
Yes,
do you
Murali.
remember that?
Yes, sure. Very
Yeah,
much.
and that tape recorder is still with me. It is
Really?
playing. It's
Oh,
working. Yeah,
Philips. Yes.
and yes. And we do play that art of living songs, I think. Am I right?
Yes, many of them.
Yeah, it was very soothing, and it was pleasant. Pleasant to take. It was a pleasant experience to take duty with you. I appreciate that. That can be carried into any of the ICUs, and that's what usually happens. It is music therapy, and so we made our ICU as a second home, considering the importance of getting critical care in the comfort of your home. This is what the newer trend is. New normal is make your ICU a second home. This is what usually done. It is evidenced by this type of care, the patient and family-centered care, which is fashionable nowadays. It is no patient-doctor relationship. It is a partnership. There will be information sharing. There will be care coordination, good mindful communication. They respect each other, which is lacking here. That's why the bystanders or surrogates used to have. If there is a good communication, they will respect us. If there is a lack in communication, the respect will be lost and partnership will be lost. Information sharing won't be there. This chain will be broken and that will end in calamities. And the rest of the 6 things I will be saying as a story. This is what we do when a patient or guest reaches our ICU. Better consider them as guests rather than calling by their diagnosis or as a patient, because we live in a country where Aditi Devo Bhava means best is code is practiced. Let's watch the journey of a guest from ER to ICU, emergency room to ICU, and from there to home. This is what usually happens. The guest will be carried to the emergency room like this. Apply extreme caution and please do no harm by casual attitude, which leads to casualties like this. So transfer with care. Inside the emergency room, the emergency physician will stabilize the patient. The most of the cases will be, majority of cases will be like this. This type of case makes you used to get heart attack, stroke, accident, palsy, mistake, right, and transfer from any other facility. And we follow stringent admission criteria for ICU admissions, depending upon their age, their severity of illness, their pre-morbid illness, pre-morbid quality of life, and guest and family wishes is also taken into consideration before admitting a patient into the ICU. Shift to any of this facility with the prior information. We do follow transport checklists so that the patient can be transported and it is prior information is given from emergency room to the ICU so that the people will be ready to receive the patient. Reception of the patient is most important inside the ICU. Usually, I do work in a level 3 ICU. There are 4 levels. Level 0 is the normal ward care. Level 1 is acute care ward maintained by the physician, and level 2 by specialist, and usually they take consultation from intensive care, and level 3 is looked after by the intensive care. This is decided by the severity of illness and doctor availability and expertise and nurse-guest ratio and monitoring facility. And from here, which is the most important part, the team, the formation of the team, which is very important inside the ICU. Inside the ICU, there will be most of the time, in the level 3 ICU, you will be getting 1:1 or 1:2 nursing most of the time, not always. Team building is very important inside. None can do it alone. That should be kept in your mind. This is what the usual ICU staffing. Our team for 30 beds. We are 6 intensive care physicians, 10 ICU residents, and 8 ICU doctors, and 90 bedside nurses, and 12 nurse team leaders, and 3 nurse supervisors. We divided these 30 beds into 3 different ICU, MDICU 1 and 2 and 3. All staffs are trained for the technical skills. As I said earlier, the nurses, they form the force behind the healthcare. They are trained in such a way that they are well versed in BLS, ACLS, ICU procedures, invasive monitoring and setting of ventilators. Everything will be taught to them. This force, there is a course running in our hospital. There's critical care nursing, CCN course is also running there. And majority of them will join there, and they will be having classes on this. Sorry. And they will be inducted into the team after this technical skill acquirement. Moreover, they are trained and retrained in such a way that they acquire these 7 soft skills. They could easily prioritize the task, set a manageable routine, learn to say no and how to break the bad news, build a support system among them. Don't be afraid to delegate the things to others. Make sure that they communicate with others as well as the surrogates, and take themselves breaks in between. These soft skills are also given to them. And most of the nurses will be trained in mindfulness meditation. They do enter the ICU after practicing this mindful meditation for 3 minutes before they enter into the shift. You can see the mindfulness. Mindfulness is nothing. Sitting in any of the place improves the mood and attention and quality of life. It helps to regulate emotions. It can be practiced anywhere. The basic thing of mindfulness is you close your eyes, sit alone, and listen to your breath. If you can listen to your breath, you will listen to others. If you can listen to others, means you will be a mindful communicator. That is the base of the mindfulness. It improves communication, prevent medical errors, and removes alarm fatigue so that they will be listening to the alarms and undo the clutter inside the body, inside the mind will be removed after being listening to your breath. And it prevents the sickness absenteeism, and it forms an ICU work culture among the ICU nurses. Not all the nurses alone can't do wonder, but supported by these dedicated members from dietary, from clinical pharmacy, and physiotherapy unit and respiratory therapy unit and infection control nurses will also join us for everyday rounds. It's a great teamwork, no doubt about that. Here comes another concept which is also purely evidence-based. It improves communication, less compliance and no litigation because it is written by the family, endorsed by us, the book is supplied by the hospital, and daily progress, their worries and concerns should be entered into that, and the nurse will endorse it. Like in the lower part, you can see, nurse will endorse it. So that the communication will be superlative communication with less compliance and less litigation. There is a conference running in Spain only concentrating on ICU diet. And we do mobilize the patient early, and nutritional support will be given to them to prevent the ICU acquired weakness. And we give priority for the sleep hygiene, no pricks or no investigation after 10 p.m. and before 5 a.m. And 6 hours of assured sleep will be given to them. And 8-hourly oral hygiene, daily body care and eye care is assured. Secondarily, change of position to prevent the skin and soft tissue injury, and choice of pillows and mattresses is also given to them. And we allow them to sleep in any position. None of us can sleep in a position where the patient is being ventilated, otherwise he is sedated and paralyzed. So we allow them and give them maximum pillows so that they can sleep like this, and they can choose their pillow size, they can choose the mattress as well. Addressing their physical, psychological, social, and spiritual needs. These 8 principles are practiced inside our ICU. Their access to care, continuity and transition of care is also discussed with them. Involvement of family and friends will be there in the case of that. Emotional support and empathy is given. Physical comfort as you have seen. Information and education about the illness will be given because they are all mindful communicators. Coordination and integration of the care is also there because there is a close proximity among team members, and respect for the patient's preferences is also there. You have seen in the video that no patient preference is given. And how can we achieve the patient preferences? We'll come to that. Let's see what happens. The patient is being transported into the ICU. Let's see what happened to the guest inside the ICU. The intensive care physician will see the patient immediately. He formulates a plan. He decides on investigation and plan consultation as per the need. Meanwhile, the family members reaches out in panic like this. This is the way usually the surrogates appear in front of the ICU. The doors will be closed for them. The nurses and security won't allow them to get into the ICU, and they will be pushing them into despair like this. And this is what usually seen in outside an ICU. The security personnel standing inside, and they are waiting. The closed door. The first video shows that there's a closed door. There's an ICU sign. There is a long corridor and a sad faces sitting and standing and looking inside. Gone are the days. Nowadays it is not practice. It is, we are open for 24 hours. We follow liberal visitation policy of 1 hour waiting. If there is any procedure, they will be asked to wait for 1 hour, maximum of 1 hour. Surrogates could go for work. They can go for work, plan visit as per their wishes, and improving their well-being. So we don't follow this restricted visitation. The liberal visitation policy is the rule, and umpteen evidences for this also there. Meanwhile, the ICU counselor escort them to this room. As I said earlier, this is our counseling room, which is aromatized with essential oil, wired with music, supplied with holy books. It is quiet in 40 decibel, below 40 decibels. And how do you maintain the patient preferences? We supply them with this NOMI chart, and the senior resident will note down their preferences when they take history about their food, habits, their newspaper of choice, their music of choice, spirituality, pillows, spectacles, and what they need to be called. Everything will be written and kept in the file. And the senior resident collects the history, present and past illness, and personal preferences for the further management. You can see items that comfort them and the things I need to, and my fears, my spiritual beliefs and practice, my favorite things, activities, food, movies, games, books, music, TV. And I prefer to be called like, and my support team, and who is the closest friend and family and pet. And you may be surprised to know, and there everything will be written and kept in the file so that the patient preferences will not be compromised inside the ICU. After that, the history will be taken, and meanwhile, the intensive care physician, after stabilizing the patient, comes out and speaks to the bystanders. And it is called patient-centered care after stabilization. And they are debriefed in a mindful way about immediate plans, long-term plans, the prognosis of the disease, its outcome, complications, and cost is also explained, noting the importance of family participation in the treatment. This is usually done by the intensive care physician soon after stabilizing the patient, after being getting the personal preferences by the senior resident in a mindful way. It is called debriefing because briefing means it is monotonous, like radio will tell. Debriefing means ask them to speak and let them speak, and they will ask questions, and we will be answering their questions. And these 6 things should be explained to them. After that, the counselor will escort to this area earmarked for them. This is the original picture. And this is the waiting area of the ICU with a washroom nearby, television set, newspaper facility is also provided. You can see a library over the corner and a cafeteria, and with an intercom facility fitted to that, so that there is no announcement for calling the patient. The nurses won't sneak out, and no yelling of patients' names or surrogates' name. And 10 briefings to keep them at ease, and they will be getting 10 briefings, 2 by the consultant in the morning and evening, and nurses 6 numbers, because it's an 8-hourly nursing. So the nurses will be giving 6 numbers every shift, and supervisor will give 2 numbers, morning and evening, and good night virtual call at 9 p.m. There is a video call at 9 p.m. to every person in the ICU, so that the surrogates could see them, what they are doing. At 9 p.m., they will be getting a night video call and keeping them at ease. And we could consider discharge if the patient regained consciousness, stabilized BP, normalized heart rate, off ventilator, mobilized in bed, and we strictly follow discharge criteria. The patient is like this, and we will extubate the patient and keep them for 24 hours and send them out to any of the HDUs or ward, or sometimes we discharge the patient directly to the home. Mostly they will move out like this. This is what usually happens. our mortality rate is comparable with the ICCM standards. And we obtain feedback from them and improvise ourselves for the continuous improvement. Negative feedbacks will be taken, and the improvement program will be suggested by the quality people. And sometimes we lose them in spite of all our efforts. This also usually happens, sometimes happens. And we follow them for 3 months in this clinic, post-ICU clinic, in the name of Phoenix. Identify post-intensive care syndrome, PICS family as well as patient and their grief, and treat SOS, and flawless documentation and outcomes are measured and quality is imparted into our care. Let me stop here, and it's time for a Zoom talk. And our strength is evolving evidences, and SCCM ABCDEF bundle endorses us to go ahead with this, and the Thrive bundle for SCCM in the PICU, that is in pediatric patient, and HUCI project from Spain also gives us strength. Our weakness is lack of level 1 evidences and no scientific advances in India. The technological boom will introduce more and more gadgets into the ICU, making it inhuman. And macro experts in micro topics is also a weakness. And commercialism in healthcare also compromises humanization. But thinking inside and outside the box, we expect a paradigm shift and a culture change for this to make the ICU kinder. And the take-home message is, beyond the humanized care, follow admission and discharge criteria, and give them an affordable cost, and no palliative care in ICU. This is what the message is. This is the end of the presentation. Thank you so much for the patient listening.
Thank you, Dr. Murali. It's a very excellent talk and a very nice presentation. I observed that you used less words and more pictures.
Thank you, Murali. Thank you.
Yeah. When you talk about the transistor, I remember my days in Trivandrum Medical College. We used to have a transistor in open heart theater, and our surgeon is very fond of listening to music. So I remember those days. I still remember that song, Tera Swayamvaram, Kathakali Kantunaruvan. I learned that song from Cardiothoracic Operation Theater. And nowadays, most of the non-medical people always wonder, inside the operation theater and ICU, you keep listening to songs. So is it possible? And I said, it's very much possible. And in my theater, we always keep music. Of course, for the cesarean section, because of the religious reasons, some patients will object for these songs. And after taking the baby out and while closing that uterus, we used to keep, and for other surgeries, it is not an issue. So you address the psychological and emotional aspects of a patient, of a nurse, and the caretaker in an ICU. Very nice approach. So I have few doubts. So if a patient is on ventilator, how you will be providing that sedation for these patients? Like you will give 24 hours sedation, or you switch to day and night shift? How often you are giving this sedation?
Sedation, we usually go for multimodal sedations. That is, but we prefer to avoid opioid-based and benzodiazepine-based sedation. We prefer to go with the alpha-2 agonist, dexmedetomidine, more of dexmedetomidine, along with a little bit of opioids and no benzodiazepine. And we give it over 24 hours. And we plan daily spontaneous awakening trial coupled with a spontaneous breathing trial, SAT plus SPT, regularly at at 6 a.m., we will reduce the sedative drugs to 30%, 50%, depending upon the patient's status, and see that the patient conscious level is assessed. And if possible, we'll continue with the spontaneous breathing trial. The coupling of SAT and SPT gives us a early liberation from the ventilator. So coupling SAT, SPT with a reduction in 30 to 50%, or sometimes we completely stop depending upon the patient's condition, and non-benzodiazepine and minimum of opioid is the rule nowadays. We follow that and we do get results. And dexmedetomidine, which also decreases the incidence of ICU delivery.
And you mentioned about the virtual calling at 9 p.m.
Yes.
So have you faced any emotional problems from the bystanders, especially about a critically ill patient who is on ventilator?
No, never. Because they do agree that they could go for sleep after seeing their loved one sleeping or ventilated or in a much more settled way. If the patient is agitated, we better don't give them a call. This started only 2 years back. We do have this virtual calling at the time of COVID illness. At that time, they are not allowed into the ICU. We started on that and we are continuing it in the non-COVID areas also. We are getting appreciation from them for this night call. Good night call, they used to say that. Good night call. We didn't get the good night call. They used to complain about it if they don't call them at 9 p.m.
Okay, that's good. And one more doubt. Now there is a movement happening outside, and they are asking for a complete video recording inside the ICU setup. So what's your opinion on that part? Especially I'm afraid about the privacy part of the privacy issues regarding this movement. So what do you think?
Bystander engagement, it is similar to that of engaging bystander inside a level 3 ICU. Into a level 3 ICU, it is very difficult because in our setting, like a resource poor setting, we don't have any cubicle-like setup, so that the privacy will be impaired. And the other person, one person, if the video is fitted into that and one person is seeing it, and one cardiac arrest may occur at any time, and that will lead on to increased anxiety to the other patients. I won't agree with that, because most of the feedback from various countries is that they tried to bring in the surrogates during cardiac arrest, and they found that it is very difficult to maintain the patient surrogates inside the ICU during the cardiac arrest. So it's better now to go for fitting a video inside the ICU with no cubicle facility. If it is a cubicle facility as well, we need umpteen cameras for that. And in our resource poor settings, I don't think it is possible. And none of the ICUs, even in the King's College, London, also not fitted with. I don't. Murali, do you have any experience of seeing a ICU
No.
level 3
I'm
ICU?
actually observing that moment, because most of the people, they are telling that the ICU is an area where so many secrets are happening and they are actually looting the patients. So I observed, and a few doctors are behind this movement.
I personally don't agree, and most of the evidences does not favor that. And to me, most of the higher-end ICUs, and one of my friend has joined in Birmingham, which is a 300-bedded ICU. It is also not fitted with the camera.
Okay. And I noted one thing. So you said there is a eight session briefing for that bystanders. So most of the time, what we face is the bystanders are changing very frequently, and they are not following the condition of the patient. So have you experienced any trouble in dealing with these bystanders, especially the frequent change of bystanders?
Yeah. We used to brief into the, we have a short form called most important surrogate, MIS. and we identify the most important surrogate. Their name will be put in the file, and we will speak. The consultant will speak to them only. Them only. If they are available, we will speak to them. No to all. No to all. The briefing is not usually done inside ICU, on the bedside, or in the corridor. We do brief inside the ICU, in the counseling room, and that too to the MIS. MIS can bring, that is most important surrogate, can bring in 1 or 2 persons during briefing. Not alone.
Okay.
Others are not allowed.
Okay, thank you. Now the session is open for further discussions.
Yeah, please.
Dr.
Brijesh.
Yes. Murali sir.
Brijesh, how do you feel? Is it a good way? There is the 7-pronged attack. All are evidence-based. And we are practicing it for the last 7-8 years, and we are getting results from that. And much appreciation.
Yes, somebody has to ask something. The session is open for discussion.
Rajesh, can I speak?
Yes, sir. Please.
It is an
Yes, sir.
excellent presentation, Murali. It was an
Thank you,
excellent
sir.
presentation, Murali. Your videos were excellent. But one practical problems we have to face, because but as Murali said, the bystanders are aging frequently, and we have to explain to each and every person. That's one of the problems that our consultant did. Then most important thing in the ICU is pain relief. We have to focus much more on the pain relief. Then expenses also. Most of the patients, you may be lucky, you are getting economically high patients, but in poor settings, all the setups may not be active. That is another problem. All the things are excellent, but practically there are some problems to follow.
Sir, sir, I agree to that. The cost is an important factor. As I said earlier, kindness means decreasing the cost. But it's possible, even we can do it in medical college setting as well. And Dr. Anil Satyadas is doing this type of care in medical college setup. They're in the MDICU, they're also practicing this humanized ICU care. And one more thing is the initial expenditure will be there, no added expenditure for this. And we are pumping in technology into our ICUs. If we can avoid one ventilator, we can do this. And one ventilator cost will give all these 7-pronged attack so that the dehumanization can be removed. The cost is a factor. I agree to you.
Murali sir.
Yes.
First of all, let me thank you for that wonderful talk. It was inspiring for many of us. And you must be aware, many of us practice in different type of setups. Some people may be practicing in a corporate setup like what you are doing. Some people may be doing general practice or in a setup where that much facilities are not there. So, but after hearing your talk, many of us may be interested in, okay, let me start the practicing it. So how would you suggest to start from a or is it always this corporate type of things always needed? Okay, I want to start it today, or I am compelling my hospital management to start. So how will I do that? What is your suggestion?
Initiate with a good communication. Be a good listener, so that if you listen to somebody and they will communicate well with you, so that the communication improves, the humanization will come to that. And if you listen to a bystander very well, and they will communicate with you, so that they will be getting well-being, we will also get well-being, and the patient is also get well-being. So communication, the mindful communication gives you the 70% of humanizing care.
Okay.
Be a good listener. You only taught me to have a good listener, right?
Yes, thank you for reminding that. Sir, I wanted to get some clarifications. You said about trained and retrained.
Yes.
What is that and how do you do that?
Knowledge attrition can occur at any time. If you give training for BLS, suppose ACLS, in ACLS and BLS schedule also, there will be retraining. You will have to go for retraining. In order to prevent the knowledge attrition, we will have to train and retrain. Otherwise, we will lose our knowledge. Knowing will be there, knowledge will be disappeared. So training and retraining is a must. That we do practice inside ICU. How is that? Is the senior member will be mentoring the juniors. So they will be teaching them. So they will brush up their memories. That's why we maintain the retraining and training of the staff. It's very important. Prevent knowledge attrition.
You somewhere in your talk, you said, learn to say no. What do you mean by that?
Usually, this is all nurses should start saying no, because hand hygiene inside ICU is very important for the infection control practices. Most of us, including myself, is very reluctant to do this. Sometimes we will forget about it. At that time, they should say no to them. Don't touch the patient. They will be empowered to say no to the doctors as well. Otherwise, it won't work. Infection control inside ICU is very important. So we added that no, saying no to anybody. If it is a doctor, senior doctor, you should say, no, sir, please don't touch. Use please, 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 number of pleases, and say no.
Yes. So that it won't hurt them.
It won't hurt them. In a much more polished or mindful way, they will be given training for that. And the almost all are seven-pronged attack, 7 soft skills, 7 technological skills.
I am reminding something comes to my mind. About before that COVID, I had an episode of cardiac arrhythmia. Initially, I was not feeling well. I did not know what is happening. Then my friend Srijit suggested we will take an ECG. Then arrhythmia was diagnosed and physicians was shown. He referred to cardiologist. And since it was the first episode, I was inside my own hospital's cardiac ICU. So one night I was spending there. So I remember, I know it is my own hospital, but things which were happening around me over the whole night. Okay, till 9 o'clock, everything was quiet. Suddenly, one patient was, I thought it will just come end like that. But suddenly at around 11 o'clock, some patient was rushed in and it was a cardiac patient. So I was listening to the resuscitation sounds, seeing one patient dying, second patient getting resuscitated at 3 o'clock in the morning, and the stress through which I have to go through. So in usual ICU setups, invariably the next patient, some patient is having a real emergency like a cardiac arrest, and the other patients will be listening to or saying all these things. So how do you manage to contain so that their sleep is disturbed? So many principles set, but in such a setup, how do you manage in your ICU?
It's very difficult to handle that situation. Even then, we tried our level best to condign this to that bed itself. There is a culture developed in the Code Blue team. That is Code Blue culture. The Code Blue people will come running inside and they will walk and reach the patient's side. And they will speak very politely and they won't yell at other team members. They won't start yelling at, but 2 minutes, stop CPR, which will be in a low voice, low tone, low voice, and confined to that team only. And the other nurse, who nurses the other person, will be standing with the patient and giving them reassurance that nothing to worry, that patient is getting better. And the team of doctors has come in and they are doing the resuscitation work. In their own words, in their own language, in their own level, they will speak to them and reinforce them and pacify them and keep them keep them in a cool stature. And the other part, the code blue team, usually from the ER, are well versed with this code blue culture. And this has, we do have a quality department, and we do get complaints regarding this type of, as you arouse this situation, we do get complaints. So we do form this code blue culture so that they will come running and walk inside, reaches there and resuscitate the patient in a low tone and do their job and go back. We tried our level best, but there are hitches in this. If you have a cubicle concept, you can reduce it to some more. And we have an East block recently constructed. In East block, all the ICU beds are in the cubicle concept, following cubicle concept, so that much more privacy will be given.
Regarding this virtual calling, I remember one incident that was before COVID. We had a transplant patient. The donor was his wife, and both of them were separated in different places. So both were eager about each other. So at that time, we were not that familiar with this virtual video calling and all those things. Then I suggested a surgeon, why don't we do that? Okay, okay, we will give the phone to him, and it worked. So both of them could see and communicate for some time, and both felt better, much better. Then again, during COVID, we tried it for a few patients because they were not allowed inside because of this COVID restraints. So it worked. So, so we can use the technology to the benefit of our patients.
Correct. Because we do have a tablet type PC inside the ICU, so that they don't need any telephone with them and no mobile phone with them, and we have a WhatsApp number. Previously, we usually go by Google Meet and all. Now we have a WhatsApp number for the ICU so that they can call in and see them at any time at their own choice. And if the staff nurses are busy, we don't allow them to do that. They don't attend the call. There are complaints, but it's not so severe nature of that.
Yeah, as you said that communication and good listening, that's a key word in ICU. I remember my days in Trivandrum Medical College. We were working in cardiothoracic unit, and we have a 4-bedded critical ICU in the 2nd floor, and the operation theater is in the ground floor. So after surgeries, daily we used to have 2 surgeries, and I'm the only one anesthetist apart from my senior doctor. So I used to visit the patients in the ICU. So evening we finish case by, this is I'm talking about 2004, 2005. So after finishing the case by 5 or 6 o'clock, we used to go to the ICU. And by that time, our chechis, attendants, they used to prepare tea and buy some parambari or paripoda from the restaurants. And we used to have these things close to the ICUs. There are 4 patients inside the ICUs. Some of them may be in the ventilator. At that time, I remember there are 3 ventilators and 1 bed, a non-ventilator patient. So we used to have this tea and snacks close to the ICU, almost inside the ICU. I can tell like that. We are not bothered about the patients. So one day, one patient, he was extubated in the morning, and in the evening he was telling, doctor, I was actually shocked. This patient was on ventilator and he was sedated. I thought it is like that. He was telling, yesterday you people were enjoying your tea and parambari, and I am still starving on ventilator. So on that day, I stopped taking all these snacks inside the ICU. So this listening and observation improve a lot the ICU culture.
ICU work culture is difficult to practice. Every time sitting sad and not talking and not smiling, it is difficult. But we contain ourselves, our emotions, and speak to them, and we can have a we can go to the counseling room and we can have tea and coffee there. And we usually don't yell at them and speak them on the bedside, nearby bedside, not in the corridor. We do brief them inside the counseling room only, and contain ourselves, and we speak less, and we speak in a low tone voice, which is very difficult even in stressful situations like a CPR and all. We will call them and we will yell at them, and it is very difficult to follow the ICU work culture in critical situations, critical incidents. I agree with that.